It's not uncommon for someone to say that they're like losing like 70, 80, even 90% of their hair with hyperthyroidism. And then what also worth mentioning with Graves specifically, there's what's called thyroid eye disease, where the immune system attacks the tissues of the eyes, and that can lead to bulging of the eyes, swelling, sometimes double vision. That, of course, could be very scary for someone who's dealing with Graves, and then they start developing eye symptoms. So we could definitely talk more about that. But those are some of the main differences with the symptoms when it comes to hyperthyroidism and hypothyroidism.
All right. Well, it's a real pleasure to have Dr. Eric Osansky on the show. Welcome.
Welcome, Zora. Great to be here. Thanks for having me.
It's great to have you here to talk about thyroid and thyroid health, which we've covered before, but we're going to take a deeper dive into Hashimoto's and Graves' disease. And I'd like to focus a little bit more on Graves' disease because I think not a lot of people are talking too much about that. But before we do, you've had your own story, personal story with Graves' disease. Why don't you share us briefly what happened to you and then how this actually got you into becoming an expert in thyroid health?
Yeah, so this happened actually it started in late 2007 when I was dieting and detoxifying, and then early led into early 2008 when I was losing weight and figured that was mostly due to the diet and had increased appetite as well. Again, thought it was mainly related to the diet and detoxifying. But one day I was walking around a retail store and they had one of those automated blood pressure machines, and I decided to take my blood pressure, my blood pressure was fine. My resting heart rate though was 90, which definitely was high, but I figured maybe it's just because I was walking around. And so the next few days I took my resting heart rate at home and it was anywhere between 90 and 110 beats per minute. And then I was like, yeah, something is up here. And I
And what
started to
should
put
it be? What should it be? What would you expect a resting heart rate to be?
mine like in the mid 60s, maybe. I would say lower 70s would be like the max that I'd want to see someone's resting heart rate to be. So yeah, like 60s, lower 70s. If it's lower than that, if someone is a marathon runner, maybe it would be in the 50s. But I was expecting it to be in the 60s or maybe in the 70s since I was walking around. But 90, I was like a little bit surprised. And then definitely 90 to 110 over resting the next few days was alarmingly high.
Okay. Yeah. So I
Yeah.
just wanted to make sure people understood, yeah, what is a normal resting heart rate? And you were way above, even though you were in good health or good condition, you were training, I guess you were doing your diet and all that. So then what happened next after you realized your blood pressure is, I mean, your heart rate is just way too high?
Yeah, so I decided to schedule with a doctor to get some labs run, and he did some basic thyroid tests, TSH, free T4, and then that revealed that I had hyperthyroidism. I had a low TSH, depressed TSH, elevated T4, and so I had hyperthyroidism, which explained at least some of the weight loss. Some of it I'm sure was due to my routine, my exercising, my dieting, but I ended up losing 42 pounds, which I went from 182 to 140, which I definitely didn't want to be that low. So it was a pretty extreme weight loss. And eventually went to an endocrinologist who did some additional testing, had the antibodies tested for Graves, and I got the diagnosis with Graves' disease, which was a complete shock. And usually is for most people. They're not expecting to get diagnosed with whether it's Graves or Hashimoto's. It's always kind of a surprise. But
And here you were
after,
doing everything right. You were losing the weight and changing the
well,
diet and what, doing everything.
yeah.
Some people go, well, just don't even touch it. Get a disease because of all of that.
Yeah, looking back, I wasn't doing everything right. One thing I'll say is that I was probably overtraining at the time, which wasn't a good thing. So it's great to exercise and not be sedentary, but I was definitely not listening to my body. So that was one stressor on my body. And then emotional stress. Adrenals definitely were a big, stress and adrenals were a big factor in my condition. So yeah, I can't say I was doing everything right.
What you believed was right. That's
Yeah,
the thing is you could think, oh, well, the more the better. Exercise is good. Let's
yeah,
do even more. And I'm losing weight and I'm happy and I feel good. And you probably have more energy. And so you can push it harder. And it's not an unusual story. And so,
agreed.
yeah, I think it, but why did you get a doctor to run your labs? You can't do your own? You're a doctor.
Oh, why did I go to a doctor, you said?
Yeah. Yeah. You can't do your own. I'm just curious why you can't do your own labs, or you just wasn't sure
Yeah,
you wanted a second opinion of what was going on.
up until that point, I was just practicing chiropractic. I really wasn't incorporating much functional medicine. So you're right. I could have
Okay.
done, and after that, I did pretty much do my own testing. I also wanted a thyroid ultrasound, which I guess I could have ordered my own, but I guess I wanted at the time, I didn't have the knowledge or experience I have now when it comes to hyperthyroidism and Graves disease. So I wanted to get the opinion from someone who had that knowledge. And I only had one appointment with the endocrinologist just to get that diagnosis. And then once I got that diagnosis, I did end up doing my own blood test. And then I didn't take the anti-thyroid medication that was recommended. And I'm not saying there's not a time and place for that, but I chose not to. So if I had to do it all over again, knowing what I know now, maybe I wouldn't have ended up going and just done my own testing. But at that time, I
Oh,
figured I would
yeah.
just, yeah,
It was before you did your functional medicine training. I didn't realize that. Okay. Yes.
yeah,
Okay.
exactly.
Yeah, because what don't they teach you every single thing when you go to medical school? I mean, come on. All right. So that's your story is interesting because now you are someone who's been in those shoes and you understand. So, and now you've been working with a lot of women now because we're focusing on women in menopause who have thyroid issues. And it seems as though so many women in my community, when I ask them how their thyroid is, many of them have thyroid issues and where they didn't have it before. So why do you think so many women are starting to have these thyroid issues once they hit perimenopause?
Yeah, it's a great question. And to be fair, we probably don't have all the answers. One answer is we know that most thyroid conditions are autoimmune. So most hypothyroid conditions are Hashimoto's, most hyperthyroid conditions are Graves. Again, there are exceptions, but I think 90% of people with hypo have Hashimoto's and similar with Graves. And estrogen sometimes gets a bad rap, but it's important for healthy immune system. And so when women hit perimenopause and especially menopause, we see those estrogen levels fluctuate and with menopause drop down and decrease. And so that seems to be one big reason why that sets the stage for, again, not necessarily directly affecting the thyroid, but more for thyroid autoimmunity, Graves and Hashimoto's. Stress, we can't just say stress. It's not like premenopause, there's no stress involved. But a lot of women hit perimenopause as well as menopause, it seems like also stress in combination with the hormones. And I think that's the one thing. It's not just one factor. I think it's a combination. Even like the estrogen, it's almost like the straw that broke the camel's back. It's not really like it's a trigger because someone has low estrogen. There needs to be other factors such as environmental triggers. According to the three-legged stool of autoimmunity, someone also needs that increased intestinal permeability, that leaky gut. So I think it's an interplay between multiple factors, but without question, the hormone fluctuations and eventually the lower hormones, I think, do play a big role in this.
Then how does estrogen, do you know how estrogen, does it play a role directly into your thyroid, like, or progesterone, testosterone, kind of how do they function? Do they function together? For example, we know thyroid function and cholesterol. There is some connection there. Is there a connection with estrogen, like whether it's too high or too low, or same thing with progesterone and testosterone?
With estrogen, there's like binding protein. You probably heard of sex hormone binding globulin. So there is that interplay a little bit with the hormones. The truth is, thyroid is more important. If you have thyroid hormone imbalances, it'll have more of an impact on the sex hormones and vice versa. Same thing with adrenals. And we learned this also like through Institute of Functional Medicine. They prioritize adrenal health. And we're taking away the autoimmune component, just talk about adrenals, thyroid, and sex hormones. So you need healthy adrenals have healthy thyroid, healthy adrenals have healthy thyroid, healthy sex hormones. And then again, healthy thyroid is important for having healthy sex hormones. So again, removing that autoimmune component, adrenals is essential. And I also heard another conversation you had. So I'm not suggesting that you had a conversation about on your podcast about a master hormone and all that. So I'm not saying that cortisol is the master hormone. So I agree with the person who you were interviewing, Dr. Amy Horniman. I actually listened to that. So thyroid hormone controls every single cell and tissue in the body. So it's definitely, again, it's hard to say. They're both important. You can't live without cortisol. You can't live without thyroid hormone. So they're both important. But I guess the point is you need healthy adrenals. Like stress affects everything. So if you have high or low cortisol, it's going to affect thyroid, which in turn is going to affect the sex hormones. So that when you talk about the interplay between thyroid and the sex hormones, It's more so the thyroid impact on the sex hormones and vice versa. It's not that if you have high or low estrogen, it can also affect thyroid as well due to those binding proteins. But we also got to consider the adrenals. That was my case too. But again, I think in my case, the adrenals more so affected the immune system, which again affected the thyroid, being that Graves is more autoimmune. So
Yeah.
hope that kind of makes sense.
Oh, it does. It does. Absolutely. It's just, yeah, hormones are such a symphony and one triggers the other. And it's just, if you look at a chart on hormones it's quite complex. And I think it's hard to figure out what affects the other, but I just see that there's this whole interplay. It's never just like this one thing. But let's talk about Hashimoto's and Graves disease, because we threw these words around and maybe somebody has no idea what they are. I understand that there are thyroid problems. There's hypo and hyper. Let's kind of break apart these two different diseases.
Yeah, so again, both are autoimmune conditions that affect the thyroid, but they affect the thyroid differently. So with Hashimoto's involves different thyroid. So there's three thyroid antibodies. So there's thyroid stimulating immunoglobulins, which are the ones that are more specific to Graves. The thyroid stimulating immunoglobulins is a type of TSH receptor antibody. And then you have thyroid peroxidase antibodies, or TPO antibodies, and these are actually the most common type of thyroid antibody. They're associated more with damage. The antibodies themselves aren't doing the damage, they're more of a consequence. And then you have thyroglobulin antibodies, which are like TPO, more specific in Hashimoto's, even though a lot of people with Graves also will have those elevated TPO antibodies. So with Hashimoto's, let's say the typical Hashimoto's patients, you're going to have damage to the thyroid gland, and the thyroid is going to produce less thyroid hormone. And as a result, you're going to have increased amounts of TSH, thyroid stimulating hormone. And the reason for that is because the pituitary gland is going to communicate with the thyroid gland, say, hey, we have lower amounts of thyroid hormone, so it's going to spit out more TSH, secrete more TSH. And with Hashimoto's, you'll get lower thyroid hormones. Now, they might be within the lab range, but suboptimal. And that's actually quite common, where T3, T4 might be within the lab range. And same thing with TSH as well. All three might be within the lab range. And that's why some doctors will just say, everything looks good. But if TSH is on the higher side, even within the lab range, but again, not within the optimal range, and thyroid hormones are low, and you got those either thyroglobulin antibodies or TPO antibodies elevated, that's typically diagnostic of Hashimoto's. Whereas with Graves, you get, again, not only low TSH, but usually undetectable TSH, like less than 0.01. And then you'll have elevated T3, T4 in the presence of those thyroid stimulating immunoglobulins. So Graves, hyper, Hashimoto's, hypo, and again, you get those different antibodies. But one more thing I should say is that it's not uncommon to have all three antibodies. I would say maybe 20 to 30% of people I work with will have all three of those antibodies, and they might initially present, let's say, with hyperthyroidism. They might see me for Graves, but they also have those thyroglobulin antibodies and or TPO antibodies. And so if we don't address the autoimmune component, there is that risk of them becoming hypo over time.
Okay, so the way I understand it, then we have hyper, which is Graves' disease, hypo, which is Hashimoto's, and you can figure out where you are based on certain markers like the TPO, the thyroid binding globulin. Is that what you said?
No, it's thyroglobulin. So
Thyroglobulin, and that's different
yes,
than the thyroid binding globulin, right?
exactly. Yes.
What is the thyroid binding globulin for?
So the thyroid binding, that's actually a type of TSH receptor antibody that I mentioned, the thyroid stimulating immunoglobulin, and then there's the thyroid binding globulin. And so that binds so TSI, thyroid stimulating immunoglobulin, is actually, it binds to the TSH receptor and it stimulates the production of thyroid hormone. So that's why with Graves, you have hyperthyroidism, because have that TSI, thyroid stimulating immunoglobulin. So with the binding globulins, it also binds to TSI. And there's a little bit of controversy in the literature. I actually have a podcast episode on that, where some suggest that it's more of an inhibitory antibody. So it might cause, again, more hypothyroidism, but then others say like the TSI, it kind of stimulates. So again, and not all labs, you can't test for it in all labs. It's not something we commonly see. We usually see more of the other three antibodies. So it's still, and maybe it's just because, again, we still don't know everything about it. But in a perfect situation, of course, we would like to see no antibodies, which if we see any of those antibodies, that indicates that there's a autoimmune response taking place.
Is it normal to have even one or two? I know people who have Hashimoto's or Graves' disease, like those numbers are pretty exorbitant. And the range is maybe less than 8 or less than 15 or whatever it is. But if somebody has one or two, that still indicates that they have some kind of autoimmune disorder. Or
Again, I know what you're saying. Yeah, the literature is conflicting a little bit. It does seem that it is normal to have, as part of the cleanup process, is the way it's described, that having a small amount of antibodies isn't abnormal. But yet, if you look at the updated reference ranges over the last few years, like if you look at thyroglobulin antibodies, for example, for LabCorp and Quest Diagnostics, which are two of the more common labs in the United States, both of them, I'm pretty sure with both, definitely with LabCorp, the range is like less than 1, which pretty much indicates that it should be 0. That wasn't the case in the past. And same thing with TPO antibodies also, like in the past, it was like 0 to 34. Now a lot of labs are going to less than 9. But again, there is some of the research does indicate that having a small amount of antibodies is normal. So like in the case of TPO antibodies, if someone has a level of, let's say, even 6, and which is within the lab range, like again, that seems like it's okay. But it seemed that was the case with the thyroglobulin antibodies until they adjusted the reference ranges. And why they adjusted that reference range and didn't make the TPO antibodies where it should be less than 1, I have no idea.
yeah. So would you be concerned if somebody was below the low range and they came with a bunch of symptoms or not? Or would you go try to treat somebody based on symptoms, even if their antibodies were low?
If someone's experiencing symptoms, I'm going to pay attention to it regardless of the antibodies. Now, if someone was presenting with thyroid symptoms, let's say more hypo symptoms, and then they had a TP, let's say if their thyroglobulin antibodies were negative or less than 1 and their TPO antibodies were 6, again, I would pay attention to their symptoms. I'm not going to say, hey, everything's great, don't worry about it. But would I focus on trying to get that TPO antibody like lower than 6? No, that wouldn't be my focus. My focus would be on working on like doing some testing, see what their imbalances are, maybe look at adrenals, look at the gut. But no, my goal is, I do like to see those antibodies as low as possible. But in this situation, I wouldn't try to get the TPO antibodies even lower. And the same with Graves. Like Graves, there's different reference ranges with the TSI, with the thyroid stimulating immunoglobulins. LabCorp, their range is 0 to 50, 0 to 0.55. If someone is like 0.53, that's kind of on the higher side, so I do want to see it lower. But if someone is, let's say, 0.25, and if everything else looks great, their thyroid's looking like their thyroid panel is within optimal range and they're feeling good, I'm not going to say, hey, we need to get that to 0. So that's, I think, a good example. And it's a little bit different because when I'm working with someone, they already had, like, again, they've been diagnosed with Graves typically, and they have that history of Graves. If someone just out of the blue had the TSI tested and it was 0.25 and not like less than detectable limits, would I get concerned? Again, in that case, I still probably wouldn't. Maybe I would say, well, let's keep an eye on it and make sure it doesn't increase over time. You might want to retest it. But so I guess to answer your question, I do pay attention to the antibodies. I do like to see them as low as possible. But if they're well within the reference range, but not quite 0 or less than detectable limits, I might say moderate, but I'm not going to get really too concerned if everything else is looking good.
That's good to know because we're a bunch of biohackers wanting to optimize and get an A plus plus. So that's why I asked. Super interesting. So I think some of the takeaway here is if you go to a doctor, you've got your symptoms, you're feeling horrible, and if the doctor says everything looks normal, you go find another doctor or you go talk to Dr. Osansky because that's not good enough. I think that's really, really important. So what we're talking about is if you know what the symptoms are, but what are the symptoms of hyper and hypo or Graves and Hashimoto's versus Graves?
Yeah, so I mentioned some of the symptoms I had, which was the elevated resting heart rate and the weight loss, the extreme weight loss in my case, increased appetite. I also had heart palpitations as well, which is pretty common. Had some tremors, not too bad, but did have some tremors. Very common to have increased bowel movements. Again, everything's the opposite of hypothyroidism, where hypothyroidism, everything slows down. With hyperthyroidism, everything speeds up. And so whereas like hypothyroidism, you get fatigue, you get weight gain, you get brain fog, you get a feeling of coldness. Again, these are more classic symptoms. Not everybody will fall into this. Same thing with Graves. Sometimes I'll see someone with Graves and they're gaining weight. They're like, hey, I wish I was losing a lot of weight, but I'm actually not losing any weight or I'm gaining weight. And so there might be other factors at play. But again, the classic symptom associated with hyperthyroidism or Graves is weight loss, weight gain with Hashimoto's. I mentioned coldness with hypothyroidism, more like heat intolerance, which could be mistaken for when talk about menopause. If someone is perimenopausal or in menopause and they're getting hot flashes, night sweats, now it could be related to the hormones, but hyperthyroidism also, you could get night sweat, like what's, because again, it's everything's increased. So you could get increased sweating. You could get what seems like it's hot flashes. Maybe it's more heat intolerance. So there is that overlap there as well. Anxiety is pretty common with hyperthyroidism. And again, with hypothyroidism, you can get anxiety, or again, there's depression and insomnia, pretty common with hyperthyroidism. Hair loss we see with both hypo and hyper. I will say it seems a lot more common. Well, like with hyperthyroidism, it seems a lot more extreme, I should say. A lot of It's not uncommon for someone to say that they're like losing like 70, 80, even 90% of their hair with hyperthyroidism. And then what also worth mentioning with Graves specifically, there's what's called thyroid eye disease, where the immune system affects the tissues of the eyes, pretty much attacks the tissues of the eyes, and that can lead to bulging of the eyes, swelling, sometimes double vision. And so that, of course, could be very scary for someone who's dealing with Graves, and then they start developing eye symptoms. And so we could definitely talk more about that. But those are some of the main differences with the symptoms when it comes to hyperthyroidism and hypothyroidism.
Yeah, the way it sounds is hypo, everything slows down. And I guess it's just the opposite of hyper, where you think about somebody who's hyper and excited and everything is running fast. But there are
Yep.
some cross. I can imagine how difficult it is to find out which is which. I mean, just based on symptoms, which is then why you probably have some suspicions and then say, let's go get testing. So what are the tests that would determine Graves' disease?
So the test for Graves, again, with both Hashimoto's and Graves, you want to do a thyroid panel. So TSH, thyroid stimulating hormone, T3, T4. I like to look at the free hormones, free T3, free T4, and then thyroid stimulating immunoglobulins. Again, you could also test the TRAB, TSH receptor antibodies, and most labs will do that. I like to do TSI because it's more specific, but that's essentially it. It's not as far as the labs that are specific for Graves. If someone has depressed TSH, elevated T3, T4, and elevated thyroid stimulating immunoglobulins, again, that's typically diagnostic of Graves.
So for Hashimoto, it sounds like almost the same tests for Hashimoto's. What's the difference? Is there a different test at all?
Yeah, so with Hashimoto's, first of all, the antibodies will be different. So you're still going to do TSH, T3, T4, and then you're going to test for thyroid globulin antibodies, thyroid peroxidase antibodies. Again, you might want to still test for that even if you have Graves, because you could have antibodies for both. And then there's also reverse T3. So reverse T3, I don't test it in my Graves patients. So reverse T3 kind of blocks. There's still some debate over what reverse T3 does, but it seems like it's a reverse T3. So you got free T3, which is the active form of thyroid hormone. So T4 converts into T3, and then and that's the active form of thyroid hormone. And then reverse T3 is the inactive form of thyroid hormone. So it seems like it blocks thyroid hormone from getting into the cell. It could be a stress response, a response to a lot of inflammation. Now, in hyperthyroidism, we almost always see elevated reverse T3. And it makes sense because if you have too much thyroid hormone, the body is going to try to do everything it can to slow it down and prevent the thyroid hormone from getting into the cell. So I don't I stopped years ago testing reverse T3 in my hyper patients because it really doesn't make a difference. Like it's not going to change what the approach I take with these people. Now with Hashimoto's, on the other hand, it might make sense to test for it because ideally you don't want to see an elevated reverse T3. Like you wouldn't expect to see it. You do see it in Hashimoto's, but whereas across the board, you'll see it in hyperthyroidism. Hashimoto's, you'll get mixed results. You get like some people where it's elevated, it might be in the 20s, and then others where it's looking fine. And again, as far as the range for that, different practitioners will have different opinions. Some will say less than 15, some will say less than 12, some will say single digits. It does seem like the lower that is, the better, as long as it's not like extremely low. But yeah, so in Hashimoto's, there's justification for testing reverse T3. And then, like I said, there's those other antibodies.
So reverse T3, you said it's the inactive form of the T3. So this is where some of the practitioners, if you're not testing reverse T3, if you say, oh, you're just T3, and T3 is fine, you got plenty of it, but we don't know if it's active. That's why you would maybe test to see if what free T3 and then the reverse T3, what's active, what's really inactive, to try to decipher it out.
So reverse T3 is actually the inactive form of not T3, but of T4. You got, again,
Ah,
T4.
okay.
T4 converts into T3, and T3 is the active form of thyroid hormone. But then T4 also can convert into reverse T3, which is the inactive form. And yeah, you could also get an idea. Let's say if you look at T4 and T3 and you see normal levels of T4, but then you see lower levels of T3, that's going to give you an idea. Well, maybe your body's not converting enough of that T4 into T3, even without looking at reverse T3. But reverse T3 could be helpful because, again, if you have elevated levels of that, you got to ask yourself why. And maybe it is just because you have that issue converting T4 to T3, but it also could be because you're dealing with a lot of cellular stress, a lot of inflammation, which, I mean, is not, obviously we're dealing with autoimmunity, so inflammation is pretty common, but you're not really looking for, you're not trying to see, yeah, I guess you are looking to see the inactive, because that's what it is, an inactive form of T4, reverse T3. But like I said, it's more for seeing like, again, what else might be going on in response to like inflammation, chronic stress. Again, most medical doctors, as you know, most medical doctors don't look at T3, let alone reverse T3. They'll just either do just a TSH, or they might do a TSH and a T4. And then sometimes you'll have to talk them into looking at T3. And sometimes they'll do total T3 and T4. So there's a difference between the free hormones and the total hormones. And again, there's justification for doing the total hormones in Hashimoto's. Like with Graves, hyperthyroidism probably doesn't really make a difference. The thyroid hormones are going to be elevated regardless. Like the total hormones, like total T4. What that means is most T4 as well as T3, most of these hormones are bound to a protein. And so when you look at total T4, and it might not say total T4, it might just say thyroxine, let's say, on a blood test. So that means it's total T4. And so like 99% of that T4 is bound to a protein, only about 1% of it is free, whereas the free T4 is what we actually see in the bloodstream. And again, I prefer the free hormones, but the argument for looking at especially total T4 is that, since, again, what I just said, 99% of thyroid hormone is bound to a protein. If you're having damage to the thyroid gland, you might want to look at that total T4 to see is it just the free hormone that's affected, or is it just that total thyroid hormone which is low? Again, most of the cases with Hashimoto, you'll see both of them low or subclinically low. But again, there's some, I'm bringing it up because there are some functional medicine practitioners who like also to look not only at the free hormones but the total hormones in Hashimoto's as well.
When it says free, does it mean it's bioavailable or it's free for use? It's not just bound to something, it's actually going somewhere?
Exactly. Yep. Yep. It's in the bloodstream. It's not bound to that protein.
Got it. It seems as though when I was growing up, I never heard of people with Hashimoto's. I didn't know about Graves. And I've met women my age who for years, if not decades, had been trying to figure out their health issues until recently they were told, oh, you have Hashimoto's. So is this something new that's in the medical world, or has this always been there and nobody's paid attention?
I don't think it's new, but I think it's more common for numerous reasons. We live in a more toxic world, and stress I think is an even bigger factor. But I think the big thing is the environmental toxins we're dealing with. And so I think autoimmunity without question is on the rise. But I also think years ago they didn't test the antibodies. My mother she tells me the story that when I was really young, that she was diagnosed with hypothyroidism, and she was put on levothyroxine, and she just stopped taking it and everything seemed to be okay. But she didn't tell me like that she was tested for Hashimoto's. It seems like years ago, decades ago, that they didn't really test for the antibodies. And I don't know if it's because they weren't as aware of Hashimoto's. And again, it probably was because also it wasn't as common, just because, as I mentioned, I think it is on the rise. And maybe years ago, like it wasn't nearly as common. And even now, where some doctors, medical doctors, are guilty of not testing for antibodies. And some say that we should do it the other way. It should be like predictive antibody testing, where we're looking at the antibodies first, because you could have antibodies for 10, 15 years, especially in the case of Hashimoto's, as well as other autoimmune conditions like Graves. Usually, if someone starts getting the symptoms associated with Graves, hyperthyroidism, they'll catch on. But if someone's experiencing weight gain and fatigue, many medical doctors will be like, maybe you just got to change your diet and it's just maybe you're working too hard. So again, Hashimoto's could get undiagnosed for 10, like I said, 10, 15 years. And so there's that argument, maybe we should be doing antibody tests first because if the antibodies are out of range, then that's going to indicate that's going to happen before the thyroid becomes out of balance. But the reason why medical doctors don't take this approach is because it doesn't really make a difference from a conventional medical standpoint. If someone has Hashimoto's or if someone has a non-autoimmune hypothyroid condition, the treatment's going to be the same, which typically is synthetic T4.
So autoimmune disease that's Graves and Hashimoto's, for example. We call them autoimmune because your immune system is attacking itself, right? So is there a difference? Can somebody be presented with suboptimal thyroid? They're not within the optimal ranges, or maybe they're out of the normal ranges, but is it possible that they don't have autoimmune, or do you just automatically say you've got this disease, which sounds horrible, but maybe what happens in that case?
Yeah, no, it's definitely possible to have not to have a thyroid condition that's not autoimmune. Like I said, about 90% of those with Hashimoto's and Graves, 90% of those with hyper and hypo, it's autoimmune. But again, that leaves about 10%. And in the case of Graves, there's a few different conditions like toxic multinodular goiter is one that is not autoimmune. There's subacute thyroiditis, which also is not autoimmune, typically caused by a virus. And then in the case of hypothyroidism, again, getting back to our toxic world, there's so many different endocrine disrupting chemicals, xenoestrogens, microplastics, flame retardants, and they can affect the immune system, but they could also directly affect the thyroid. So if someone is presenting with thyroid symptoms and yet it doesn't appear to be autoimmune, the challenge is also you can have false negative antibodies on a test. So just because you do the antibodies and are negative doesn't 100% rule out autoimmunity, which then makes it challenging. How do you know if it's autoimmune or if it's not autoimmune? But yeah, it certainly is possible for someone to have a thyroid problem without it being Graves or Hashimoto's.
So going back to the Graves disease, when you have hyperthyroidism, it sounds like everything speeds up and fast weight loss, high heart rate. I'm wondering if this would ever be crossed, or if you're looking at a woman who's still menstruating and she loses her period, amenorrhea, is that also kind of a clue for possible Graves disease? If that, in addition to all the other ones?
Could be, yeah. With hyperthyroidism itself, it doesn't have to be Graves, but it could be again toxic multinodular goiter. But yeah, when you have hyperthyroidism, it's unpredictable. It can cause like I see it where a woman will stop cycling for a few months and then she's questioning, hey, am I perimenopausal or heading toward menopause? But it definitely could be the thyroid. Sometimes we see the opposite where they're cycling more frequently, so it's a little bit unpredictable. But if someone, yeah, it is a good point. If a woman with hyperthyroidism, if they're not cycling, if they stop cycling for a few months, especially if it gets more challenging, if they're the late 40s, early 50s, then we don't know. Is it due to the thyroid? Is it due to perimenopause? But if it's late 30s, let's say, mid 30s, late 30s, early 40s, again, still could be early menopause, but also very well could be related to the hyperthyroidism.
Yeah, I'm thinking of somebody, if they were like you, for example, she's training really hard and she's fasting and she's losing all this weight, and then suddenly she loses her period. So it's kind of like, oh, you may not have even thought perhaps you'd be in Graves' disease with this issue. I'm not saying that if anyone loses weight quickly and all that, like that's a bad thing, but where is this tipping point? So perhaps maybe we could talk about some of the triggers, or why do some people get Graves' disease?
Yeah, so there's again what's called that triad of autoimmunity, that three-legged stool of autoimmunity. So there does seem to be a genetic component, a genetic predisposition. But the good news is even if you have the genetics, you could overcome it by addressing the environmental triggers, as well as again, I mentioned that increase in intestinal permeability, that leaky gut. So again, genetics, triggers, leaky gut, those are the three factors that cause both Graves and Hashimoto's. And so, what are the different triggers that someone could have? Food, potentially, in some cases, could be a factor.
Meaning
Things like
too much food, what kind of food, timing of food? What do you mean food?
inflammatory, eating inflammatory foods. Most practitioners will recommend for the Graves and Hashimoto's patients to avoid gluten, to avoid dairy. And I know there's health benefits for dairy, because I'm not saying across the board, but gluten could potentially affect permeability of the gut, which again, most most thyroid conditions are autoimmune. Stress, like I said, in my situation, it was, I think, a combination of the emotional stressors and the physical stresses of overtraining. Trauma from many years ago could even be a factor. Chemicals, I mentioned also our toxic world being a reason why we're probably seeing more cases of Hashimoto's and Graves. And then infections, certain infections could also be a trigger. So in the literature, there a correlation doesn't always mean causation, but if you do some searching, and again, we'll talk about like journal articles and PubMed. So viruses like Epstein-Barr, H. pylori, which is found in the stomach. There's numerous articles showing relationship between Epstein-Barr and Graves and Hashimoto's. H. pylori, Graves and Hashimoto's, Yersinia enterolytica, also with Graves and Hashimoto's, parasites. So far, nothing I've seen with Graves, at least in the literature. There's a few case studies with Blastocystis hominis and Hashimoto's. Again, Lyme disease potentially, and Bartonella, and thyroid autoimmunity. So again, those are like the four, what I call four main categories of trigger. So we got stress, we got food, we got stress, we got chemicals, we got infections, things like toxic molds, which would fall into that environmental toxin category, mycotoxins. But again, it's challenging because there are a lot of different factors that could be triggers. In my book, Hashimoto's Triggers, is like 500 plus pages. So it gets pretty extensive, and you need to do some extensive detective work in some cases. Sometimes just cleaning up the diet, just eating an anti-inflammatory diet, managing your stress, getting sufficient sleep, which everybody should be working on. So start with the foundations. And sometimes that alone is enough to heal someone, but many times you need to dig deeper.
Are those triggers the same for Graves and Hashimoto's?
Yeah, for the most part, yeah. There's definitely overlap. So yeah, the four categories of triggers would apply to both Graves and Hashimoto's. I would say I probably see H. pylori more so in the Graves patients. And again, it doesn't always mean it's a trigger. It maybe someone's presenting with multiple factors. Their adrenals are shot and they have H. pylori. And is it the H. pylori or is it the stress affecting the adrenals? We don't know. And as a functional medicine practitioner, hopefully most like myself would address both the adrenals and take a natural approach for H. pylori. I'm not a big fan with the antibiotics. Time and place for antibiotics, but with H. pylori, unfortunately, I recommend two antibiotics and sometimes three, like triple or quadruple therapy, just because it's so difficult to eradicate. Again, I mentioned the literature that parasites, there's that relationship between parasites and Hashimoto's, but not with Graves. But again, in my practice, I've seen some cases of parasites where we address that and the people with Graves get a remission. So yeah, I would say the triggers, I kid around sometimes where I say if I took the book Hashimoto's Triggers and crossed out Hashimoto's and put Graves' disease, that like most of the information would be the same as far as the triggers for Graves and Hashimoto's. So the answer is yeah, pretty much most of them are the
Interesting.
same.
Yeah. So that's interesting. So it's kind of like, oh, well, we want to prevent this or correct it. And then that it's kind of most hard I guess you do the same protocol, but are there what's the determining factor? Let's say somebody, your story, okay, there was stress and there was physical and emotional stress and that rapid weight loss or maybe mold or say there's these things that are happening in their lives. When does the body decide I'm going to be Graves or I'm going to be Hashimoto's?
It's a good question. Like I said, part of that triad of autoimmunity, there is that genetic predisposition. So whether someone has Graves, Hashimoto's, rheumatoid arthritis, multiple sclerosis, lupus, all these are different autoimmune conditions. And again, the triggers, same thing. The triggers are going to be the one exception may be celiac disease. Celiac disease, it's gluten, you avoid gluten. And again, you live happily ever after. But for most of these other autoimmune conditions, there's going to be multiple factors. But again, genetics does seem to determine why someone would develop one autoimmune condition, or again, might develop the antibodies for both Graves and Hashimoto's. Now, what would be the reason why someone has the antibodies for both Graves and Hashimoto's, but they're hyper and not hypo? Like, why did they develop Graves first, kind of like, but not Hashimoto's? And again, I don't have the answer to that. I don't know anybody who does, but same thing. Like, if you were to do an autoimmune panel, and you could do it at a regular lab or Cyrex labs, they have like their Array 5 that looks at a couple of dozen different ones. Again, there are some people, it wouldn't be uncommon for people to have auto antibodies even though they're not experiencing symptoms. For example, maybe they have antibodies related to attacking the brain, the white matter of the brain. So they have pretty much MS antibodies or rheumatoid arthritis antibodies, but they're not having those symptoms. And again, maybe they would never have symptoms in the future. Maybe they will. But again, why do they have those antibodies in the first place is getting back to the original question. And it does seem like the genetics, as far as why some people develop different autoimmune different, like why does someone develop MS and not Graves or Hashimoto's? Why does someone develop rheumatoid arthritis? Why does someone develop celiac disease? Again, there does seem to be that genetic component determining why someone will develop one autoimmune condition in relation to another. But one more thing to add that's important is if you have one autoimmune condition, you're more likely to develop other autoimmune conditions in the future. So I think it's safe to say that, again, we all have genetics that could make us susceptible to different autoimmune conditions, but it's more the environment that determines why don't we all have 3 or 4 known autoimmune conditions, even if we have the genes. And it's because some people live healthier lifestyles, some people have kinder genetics that allow them to detoxify better than others. So again, some things we can't completely control. So we do need to consider the genetics, but like I said, the good news is environment does play a greater role, like what we do from a diet and lifestyle perspective, finding, removing triggers, improving the health of the gut. They could definitely override the genetics.
Yeah, and I think maybe they can flip flop. I have a friend who had thyroid cancer when she was, I don't know, maybe in her 40s. And she said she first was had hyperthyroid, then she went down to hypo and just sort of flip flopped in the same person. And that's possible too, right?
Will you go back between hyper and hypo?
Yes.
Yeah, that could happen. I also didn't mention earlier, are you familiar with Hashimotoxicosis?
No, what's that?
Yeah, so Hashimotoxicosis, essentially it's what Hashimoto's, a lot of women with Hashimoto's, or men too, who have Hashimoto's, a lot of people with Hashimoto's experience transient hyperthyroidism. But if you were to look at the antibodies, they wouldn't have those thyroid stimulating immunoglobulins. So they don't have the Graves antibodies. They just have the Hashimoto's antibodies. But when the immune system attacks the thyroid gland, you could get a rush of thyroid hormone into the bloodstream, presenting with hyperthyroidism. And it might only last a few days. Some cases it could last longer, like a few weeks. But again, so Hashimotoxicosis is Hashimoto's presenting with transient hyperthyroidism. And I'm bringing that up because in that case, you might present with hyperthyroidism initially, and you might feel like, hey, do I have Graves? If you're familiar with what Graves is, and then you do a test, and the Graves antibodies come back negative, so you're not sure. But if you do the Hashimoto's antibodies and come back positive, then again, the good chance you have Hashimotoxicosis, and eventually you'll probably switch back to hypothyroidism, or not back. You might, like I said, present initially as hyper, and then eventually be hypo.
Well, your book is chock-a-block full of information. It is, you're right, like 500 plus pages, and it has so much detail. And then you do present, yeah, actually the cure for this, which is I want to talk about next, for hypo or hyperthyroidism are very similar. There's very few differences. So why don't we discuss a little bit what if somebody's been just diagnosed with Graves' disease, for example, what should she be doing? What's the first step?
Well, the first thing, which is where it becomes different than what Hashimoto's is, you want to lower those thyroid hormones. Obviously, you want to address the cause of the problem, which we're about to talk about, but you don't want to have, just like with Hashimoto's, you don't want thyroid hormone to be too low. There's a time and place for thyroid hormone replacements. In Graves, when thyroid hormones are too high, you want to do things to lower thyroid hormones. In my case, I took an herbal approach, but there's also the anti-thyroid medication. So a lot of my patients do take methimazole, is most commonly given in the United States, also known as tapazole. Some other in other countries, there what's called carbimazole that converts into methimazole, and then there's also propylthiouracil or PTU. So those are the different types of anti-thyroid medication. The reason why a lot of people don't like them is because side effects are common, but they do work. And most people, they do work. And if someone is working with me and they're also working with an endocrinologist and they're taking an anti-thyroid medication, and if they're tolerating it well and their liver enzymes and white blood cell count looks good, then again, it's not the end of the world to take it while addressing the cause of the problem. When I dealt with Graves, prior to my Graves diagnosis, I took a lot of nutrition courses as part of my continuing education credits as a chiropractor. Again, I didn't practice functional medicine, but I just love nutrition. And I did take a couple of I attended a couple of endocrinology seminars, functional endocrinology seminars, and they spoke about the herbs bugleweed and motherwort, which bugleweed is a natural anti-thyroid herb. Motherwort is kind of like a natural beta blocker. And so when I dealt with Graves, I was like, you know what? I'm going to give those a try. I knew nothing about the herbs other than what I learned at the seminar. Didn't know anyone else who had success with those, but I decided to take those and they really helped. They helped not only symptom wise, but when I did my next blood test, I did see a difference. So the bugleweed definitely was working. The motherwort was helping. There's a few others. A lemon balm I didn't take, but that's something commonly taken by people with hyperthyroidism. And but yeah, so safe symptom management. You want to make sure you lower those thyroid hormones, because if thyroid hormones are elevated, it could put it stressful on the heart. Also has a negative effect on bone density. So yeah, that's the number one thing while addressing the cause of the problem. And then yeah, with both Graves and Hashimoto's, I would say focus on the foundations, like initially, clean up your diet, eat an anti-inflammatory diet. In the books, I talk about the autoimmune protocol, AIP diet. It's not a perfect diet for everyone. Some people might do better just on a regular paleo diet or a modified paleo diet. Point is, you want to avoid the inflammatory foods, the refined foods and sugars, the fast food, the unhealthy oils. And then also stress management is important. Again, getting sufficient sleep is important. Doing at least some basic things from a toxic burden standpoint, using like natural cleaners and cosmetics in your home and purifying your water and your air. And testing. I talk about in all my books, especially Hashimoto's triggers and natural treatment solutions for hyperthyroidism and Graves' disease, digging deeper and going beyond diet and lifestyle many times is necessary. So we might need to do some testing to look at the adrenals, to look at the gut microbiome, to look at other imbalances to see what we might need to address.
Interesting. Yeah. So these are you rattled off some of the medications that people may take. And it sounds amazing that you can take an herb that will have the same effect. Honestly, it's why wouldn't you even go down that route? So you mentioned you want to suppress thyroid. Thyroid's too high, anti-thyroid. So what about the cures or the options for treatments for someone who has Hashimoto's and their thyroid levels are too low?
Yeah, so great question. So when thyroid hormone is too low, unfortunately, there's not an herbal replacement for thyroid hormone because again with hyperthyroidism, we're trying to suppress it. For Hashimoto's, we're replacing. We need to again, we want to address the cause of the problem, but in some cases, replacement is necessary, and there's not like an herbal substitute for thyroid hormone. So in this case, I mentioned earlier, I believe that most medical doctors recommend synthetic T4 like levothyroxine. The problem, and again, there's a time and place for that. Some people do fine taking levothyroxine. Synthroid is most commonly given, but a lot of people have issues converting T4 to T3. So if you're just taking T4, then you're not getting that conversion. So I like, given a choice, I would say desiccated thyroid, like NP thyroid or Armor, which has T4, T3, also has T1, T2, a little bit not. T2 is getting a little bit more popular because it's now like some recommended as supplements, but still you can't test for T1 and T2 in a blood test. You can only test for T3 and T4. But I do like desiccated thyroid hormone over synthetic thyroid hormone. But again, if someone is unable to get desiccated thyroid because their doctor's not prescribing it, then they might have to take it. Or again, there's thyroid glandulars to look into as well, which again, that has also T4, T3, and again, does not require a prescription. But yeah, I do like the desiccated over synthetic.
So the Glandulars are interesting because that's we talked to Dr. Amy Horniman as well. She's got all her supplements out there, and I know she has a glandular. How effective would that be in helping someone's thyroid?
It could be effective. The downside of glandulars is A, you don't know how much thyroid hormones in them. That's one downside. And then also the dosing is different. For example, one of the more common ones, at least the ones I know, is a company called Thyrogold. And I've had patients where they've taken that instead of thyroid hormone, and it seems like it's working well, but they only have two strengths, like 150 milligrams and 300 milligrams. Again, it's not going to say, it's not even going to say it has thyroid hormone on the website, let alone how much thyroid hormone is in there. But I guess the advantage of the prescriptions is there's more dosing options. If 150 milligrams is too strong for someone, there's not a lower option. If someone needs more than 300 milligrams, of course they could take 300 and combine that with 150. But yeah, the thyroid glandulars for someone who is unable to get that prescription, because like I said, some medical doctors are resistant to recommends it. And they'll give different reasons. One reason is because they'll say that it's not standardized, that even with Armor or NP thyroid, that like it differs from batch to batch. And which again, I'm not an expert, so I don't, but again, all I know is that there's a lot of people that have taken those. Like I don't test the batches, so I don't know if that's true or not. But I don't think the medical doctors who say that do that either. But I think there is that also inherent bias. And I think really what it comes down to is everybody's different. So when you got to keep an open mind. If someone's taking synthetic thyroid hormone and they're not feeling good, well, maybe they could take cytomel, which is synthetic T3. So maybe that's a solution. But again, why not give desiccated thyroid a try? And I think we got to look both ways too. As natural healthcare practitioners, there's been patients of mine who took desiccated thyroid and they actually felt better on the synthetic thyroid. Now, I don't know why, but again, if that's the case, I'm not going to try to talk them out of and say, no, stay away from the synthetic T4. Maybe they'll want to try one that's more like hypoallergenic, like Tirosint instead of Synthroid. But either way, everybody's different. And yeah, so I think either way, you want to keep an open mind.
I think it's very important to, yeah, to understand. Also, people have different approaches, and some would say, I want to know exact dosage. I don't want to mess around with fluctuations and whatever. I feel better, fine. And then you may have other people say, I want quote unquote natural, and I like to have fluctuations, or I understand that the body is different. Everybody can come up with their own justification for taking whatever it is that they want. But it's great that we have an option and they can make a choice. And with somebody who's open-minded like you is not going to bully somebody into doing something that you think is the best for everybody. The thing that's interesting that I've noticed over the years is that my husband actually is one of them. He had thyroid cancer when he was in his 30s. So he's been on levothyroxine T4 for decades, and probably 3 decades now. And he's never changed it, never changed the dose. And as I'm learning through experts like you, most of them would say, well, why are you taking just T4? You need T3 as well. But when he took the T3, he felt worse. And he goes back to his own thing, right? But I'm wondering, is that standard of care? Just if somebody's got poor thyroid health, just take the levothyroxine T4 and not even explore T3?
Yeah, from a conventional medical standpoint, yeah, exactly. And at least not only United States, but a lot of other countries too. It's pretty much just synthetic T4. And again, they might be open to T3. Like most are not in favor of the desiccated thyroid. And again, your husband, maybe it's not like everybody has a problem converting T4 to T3. So he might do fine converting T4 to T3 and not need the extra T3. So I agree. I would not say that everybody who takes synthetic T4 needs T3. So when you take desiccated thyroid, that does have the T3 in small amounts. And that could also be maybe why some people just don't do well because, again, everybody's different and maybe they don't do well with the T3. But yeah, here it's pretty much take levothyroxine, usually Synthroid. And again, there'll be exceptions, of course. Some medical doctors who practice functional medicine might be open to recommending desiccated thyroid hormone, but more times than not, they just say just stick with the T4, and they'll go by the labs, just do a TSH, maybe a T4, but many times just look at a TSH, and as long as the TSH is within the lab range, they'll just pay attention to that.
With those people who are taking T4 and they come to you and they still feel bad on their T4, what is your protocol? You look at their labs and see if they're not converting T3, then you give them T3, or do you say, let's go with desiccated pig thyroid, or you say, let's change the diet? Like, what would you be looking at if they weren't converting to T3?
Yeah, it's a good question. So if if they did a thyroid panel, they were taking levothyroxine, T4 looked great, T3 was maybe within range, but kind of on the lower side, which indicates a conversion problem. The number one thing I would say is, well, why aren't you converting T4 to T3? And there could be numerous reasons. Most of the conversion takes place in the liver. About 60% of conversion of T4 to T3 takes place in the liver. About 20% takes place in the gut. And stress also, like if someone has high cortisol, that could affect T4 to T3. So it still comes down to those foundations. So stress, gut health, reducing toxic burden, all those could play. So that person might need to take T3, but and I might say, especially if they're experiencing hypothyroid symptoms. Again, I don't have prescribing rights, so I wouldn't be the one prescribing T3, but I might say, why don't you go to your doctor, which again, it's a catch-22 because they might not they might not test T3 to begin with, let alone pay attention to T3. So they might have to go to numerous doctors, or again, maybe they just take a thyroid glandular instead of the T4. Again, I'm not going to be telling them to stop the T. There's some people that'll take the thyroid glandular in addition to the synthetic T4. Like they'll just add that, but again, they might be getting a little bit too much T4. You don't know until you see how you feel and see what the blood test, but they might do that if they absolutely can't get what they're looking for from their medical doctor and they're taking things into their own hand. But I'm always going to try to see if we could address that conversion problem. Like to me, taking T3 wouldn't be, maybe sometimes someone will need to take it long term, but I'd like to try to see if we could address it and address that conversion problem.
So the going back, so there you have these are the medications that you can take, or I would almost argue the desiccated pig thyroid. I don't know, it's thyroid hormone. I almost don't classify it as a medication coming from a pig. But what about going to the herbs or glandulars, bioregulator peptides, for example? Some people are taking those. I myself actually was really interesting as my thyroid is suboptimal. I haven't been diagnosed with anything yet, but my doctor, I've been through many doctors. Some say take T3, some say T4, some say take desiccated pig thyroid. I kind of went through it all. And the latest doctor I had said, I don't want you on desiccated pig thyroid. It's illegal in Spain anyways. You won't be able to get it. So he gave me this supplement with a bunch of things in it, including algae and all of the other stuff. And I said, this is not going to work. It's just a supplement. And it actually started to move the needle. And I was really surprised. So I asked around, and it seemed to be that it was herb called Coleus foscoheli. I don't know if that's something you're familiar with, but it was kind of pinpointed. It's probably that, and maybe even the algae. Have you heard of that?
Yeah, coleus, it's commonly added with, there's a lot of thyroid support supplements. So we see things like coleus, tyrosine, like things that coleus is an herb, tyrosine, of course, an amino acid. But yeah, potentially, I guess ashwagandha is another one. Ashwagandha affects the HPT axis, the hypothalamic pituitary thyroid axis. So in some cases, maybe it could help with production of thyroid hormone. It really depends on the cause. If someone has Hashimoto's where you're getting damage to the thyroid gland, again, that's more of an immune system problem. So taking something like ashwagandha, coleus, iodine, I'm not saying it can never help, but it's not going to address that autoimmune component, but it's not going to be usually not going to be that replacement for thyroid hormone. But yeah, sometimes those thyroid, again, there's a lot of them out there that a lot of them do have coleus, and then they'll have other things as well. Some of them will have algae, or they'll have kelp or other sources of iodine. And again, iodine, another controversial area in the world of thyroid health. But if you're deficient in iodine, that's definitely could affect thyroid function in a negative way, as could tyrosine, again, important when it comes to thyroid hormone production. So yeah, it's one of those things where there's so many things out there, and it's not uncommon where I'll have a patient try something on their own and they might say, you know what, I feel great. You mentioned the peptides, which I'm still like learning. One's like BPC 157 for the gut, and some people they'll swear by it. Or again, maybe it's like black cumin or something else. And it'll be like, I tried this, I feel great. And I'll be like, you know what? In most cases, it depends what it is. If it's something I'm really opposed to, then we might have to see, just make sure the risks aren't outweighing the benefits. But for some of these other things I mentioned, like black cumin or the peptides, again, if they're, or the coleus, if someone is taking these and it seems like it's helping, who am I to say, no, stop taking these? I'll be like, that's great. If it's helping how you feel and the blood tests are looking better, or even if they're not looking better, but you're still feeling better, again, is it a placebo effect? I don't know. But again, if you're feeling better and the thyroid hormones are looking better and or the TSH by taking Coleus or some of these other things, again, I definitely would be in favor of it.
Okay. The foundation that you talked about diet, detoxing, testing, stress management, but you didn't mention exercise. And I'm wondering because when we think about, and you didn't mention fasting, a lot of people do. So I have a feeling that over exercising, overtraining, and over fasting probably have negative effects on the thyroid. And women who have suboptimal thyroid or thyroid issues, how do they still exercise, or if they want to fast, I don't know. Are they allowed? What do you normally recommend for that?
Yeah, great questions. I do talk about these in my books. I talk about exercise. What I will say with hyperthyroidism, I'm more cautious because if someone already has like a resting heart rate that's on the higher side and sometimes in triple digits, I would recommend for them to limit the cardio and focus more, do maybe some light walking, focus more on the resistance exercise. I think either situation, regular movement is important. So yeah, like you don't want to be a couch potato, whether you have Hashimoto's or Graves. So I think, yeah, you could definitely overdo it with the cardiovascular. And that's was my problem prior to developing Graves. It wasn't doing too much weightlifting. It was just, again, doing too much rowing machine and other things. Some people, it's again, the marathons. And again, not saying anything that negative, but again, just not listening to your body. Fasting, same thing. I talk about, I don't know if I spoke about it in Hashimoto's triggers, but I do talk about it in the Hyperthyroid Healing Diet just because it's such a hot topic. And I talk about how I do regular intermittent fasting. I think just, and again, I might do like 14 to 16 hours. But well, a few things with fasting. Sometimes I mean, I've had some patients where they're doing like 20-hour fast on a daily basis and only a 4-hour eating window. I think that's a little bit too extreme. You're not very difficult to get enough protein. But then even while someone is healing, a 16-8 might be still a little bit too much for some people, not everybody. Again, especially if someone has hyperthyroidism, if they're losing a lot of weight, if someone's adrenals are really in bad shape. Again, maybe they're better off doing 12 to 14 hours. I think just about everybody can do a 12-hour and probably should be doing like an overnight 12-hour fast. But yeah, I'm not definitely not against the fasting and definitely in favor of exercise. But I would agree you want to be cautious because if you overtrain or if you do extreme fasting, that could have negative effects on both your adrenal health and your immune system health.
Yeah, I always recommend the women I see in our community who are going through menopause are tend to be over training, under recovered, fasting way too much. And I always have a feeling that maybe their thyroid is taking an impact with that. I know that I've been training in a fasted state myself for years because I thought it was good for me until I realized it wasn't. And I have a feeling that's probably got something to do with my suboptimal thyroid. The only thing is that I've been pretty sedentary for the last 2 years with hip osteoarthritis and then the
Yeah.
surgeries and stuff. And it seems to be like creeping back with that little bit of a supplement that I've been taking. But I'm wondering if if that were, say, a trigger, just by removing those triggers, or wouldn't it just come back to normal? Or is you just kind of for life now? You're going to have suboptimal thyroid.
I wouldn't say for life, but let's say like in my situation, if like overtraining was a factor with Graves, and again, I don't think it was like the factor. I think it was maybe a piece of the puzzle. And so I think like getting back to my situation, like just not overtraining wasn't going to restore my health. And I think in most people, that's the case too. First of all, it's probably usually not the only factor. Usually there's other things in combination. Like if someone's doing extreme fasting or overtraining, there's probably other things that need to be addressed. So usually just getting back to not fasting extremely or not overtraining, I'd say in most cases isn't going to restore someone's health, that they still need to incorporate those foundations that we mentioned and the stress management and all the good stuff. But again, everybody's different. So yeah, there might be some people that just say, hey, you know what? Maybe I should just stop exercising regularly. I'm sorry, like
Normal,
overtraining,
yeah, no, over, yeah, instead of intense, yeah.
overtraining regularly. And then, yeah, just go back to regular exercise. And maybe that would be enough to heal. But like I said, I think in most cases, it's not just the overtraining. If we're talking about just the impact of fasting, if you do extreme fasting and if it's slowing down the thyroid, again, not talk about autoimmunity, but just the impact of the thyroid, and then you start eating healthy and not doing the extreme fasting, yeah, the thyroid by itself might go back to normal. But when it comes to autoimmunity, like what causes the autoimmune response, so a lot of times it's not as simple. If someone's eating a lot of gluten and then over time they develop autoimmunity. And again, it's challenging because maybe there was other things besides the gluten, and that's why a lot of times they might cut out the gluten. And again, for celiac disease, that's fine. You cut out gluten, celiac disease will, at least the antibodies will normalize and all that as long as you avoid gluten. But with Graves and Hashimoto, it's not always that simple, but sometimes it is. If you visit my Facebook groups, there'll be people who that's all they did was avoid gluten and they say everything's great. I don't know if their antibodies are normal, but some people at least say that they cured just with diet alone. So I think again it comes down to everybody's difference. So in some cases maybe just undoing those things to begin with and not doing extreme fasting, extreme exercise might be enough. In the case of thyroid autoimmunity, a lot of times you need to still go beyond that.
Okay, I have to let you go. We've gone way over time. I was super interested. I didn't even realize it. But before I do let you go, let's sort of rapid fire question. I know it's going to be hard, but you're a nutritionist. You're a functional medicine practitioner specializing in thyroid function. So what is the one food someone with Hashimoto's must stay away from and one she should absolutely include in her diet every single day?
So I mean, I'll say a category of food that they should stay with. So again, gluten, I think we, as functional medicine practitioners, all agree is inflammatory or could be inflammatory. So I would recommend avoiding foods with gluten. And then as far as foods that they should eat, I'm going to say cruciferous vegetables. And again, a little bit controversial because some will say that you should avoid cruciferous vegetables when you have a hypothyroidism because they are goitrogenic. But again, if you look at the research really hasn't shown that to be true in humans. It's animal studies. And again, I've intentionally tried to have people with hyperthyroidism eat cruciferous vegetables to inhibit thyroid hormone, and it didn't work. And they're such healthy foods. They have such great benefits, help support detoxification. So I'm going to go against what a lot of people are recommending and say, eat your broccoli, eat your Brussels sprouts, eat your kale.
Awesome. Yeah, I heard a podcast episode all about this. It's really good. Your podcast is amazing. I love it. And anybody can find it on Apple or Spotify, wherever you listen to your podcast, called Save My Thyroid. You've got the books that are out. I'm going to have a link to in the show notes. And you've got a good newsletter also, the Healthy Gut, Healthy Thyroid newsletter. I'll have links to your YouTube and your Facebook and your Instagram and that group. I absolutely think you're doing amazing work and helping so many people with their thyroid issues where they're getting ignored by their own practitioners. So you're scooping up these people and helping them save the day. So is there anything else that you'd like to mention that we forgot or haven't covered yet?
Not really. Just again, just to say that there is hope. If you're dealing with, whether you're dealing with Graves or Hashimoto's or even a non-autoimmune thyroid condition, there's always hope. And unfortunately, when you go to your regular medical doctor, they're probably just going to give you a prescription and say that there's nothing you could do to address the cause of the problem. But in most cases, there are things you could do to further improve your health as well. And in many cases, reverse the autoimmune component of Graves and Hashimoto's.
Is it ever too late to save your thyroid?
With hyperthyroidism, no, because you're not really getting the damage to the thyroid. You're just getting more of the stimulation, like the antibodies binding to the TSH receptors. For Hashimoto's, it can be more challenging in some cases if someone's taking a large dose of thyroid hormone and they've been on that for 20 years, it could be. So I won't say that it's impossible, but in some cases with Hashimoto's, it could be more challenging. But then there are other cases where they absolutely can get to the point where they don't need the thyroid hormone. But if they were just following the advice of their medical doctor, endocrinologist, they would still be taking the thyroid hormone because they're not doing anything to address the underlying cause.
Amazing. Thank you so much, Dr. Eric Osansky, and everyone else who's made it to the end of this show. I hope you learned a lot about thyroid health, and I'm excited to have you on again because I still have a whole other list of questions. So have a good day.
Yeah. Thanks, Zara.
You're welcome. Bye-bye.
Bye-bye.